All right, let's talk about a word that for a lot of people comes with a bit of a wince. Episiotomy. You've probably heard of it, especially if you've been thinking about childbirth, but what is it really? It's a topic that's surrounded by a ton of questions, maybe even some myths. So today, we're going to break it all down and demystify it, piece by piece. So here's what we're going to cover. First, what exactly is an episiotomy? Then, why would a doctor even perform one? We'll get into the procedure itself and the different types. After that, we'll talk about recovery and the potential risks. And finally, and this is super important, we'll look at the modern medical view on the whole thing.
Okay, first things first. What is an episiotomy? Let's get right down to basics and figure out what this procedure is all about. Yeah, a planned cut during childbirth? I mean, when you put it like that, it sounds pretty intense, right? And honestly, that's basically what it is. But there's a lot more to it, so let's break down what it means in medical terms.
So in plain English, an episiotomy is a small, intentional cut. It's made in the area between the vagina and the anus. That area is called the perineum. The whole point is to make the vaginal opening a little bigger to help the baby come out more easily and safely. It's done right during the second stage of labor, the pushing stage.
Okay, so if it's an intentional cut, you have to wonder, why? Why would a doctor or midwife choose to do this? Let's dig into the medical thinking behind it.
The main goals here are all about making a difficult moment safer and maybe a bit quicker. If the baby is in distress, a bigger opening can shorten that final stage of labor. And for a long, long time, the thinking was, hey, a clean surgical cut has got to be better than a random jagged tear, right? It was seen as a way to control the situation. Plus, if doctors need to use tools like forceps or vacuum to help the baby out, that extra space is absolutely necessary.
Now, this isn't something that's just done on a whim. There are very specific reasons. For the mother, it might be that her tissues just aren't stretching enough, which is pretty common for first delivery. Or there could be a serious complication like the baby's shoulder getting stuck. That's called shoulder dystocia. And from the baby's side, well, if the baby is showing signs of distress, is in a breech or feet first position, or is very premature, getting them out quickly becomes the top priority.
All right, so we've covered the what and the why. Now let's get into the how. What actually happens during the procedure? And what are the different kinds of cuts? So there are basically two main options, and each one has its own set of pros and cons. It's a real trade-off. First, you've got the midline cut. It goes straight down towards the anus. The good thing? It's usually easier to stitch up, bleeds less, and the recovery can be less painful. The big downside, though, there's a much higher risk that the tear could extend all the way to the anus, which can cause serious problems. Then there's the medial lateral cut. This one is done at an angle. It's great because it almost guarantees you won't have that injury to the anus. But it's often harder to repair, it can bleed more, and recovery can be more painful. See? A real trade-off. So, given those two choices, which one do doctors usually go with? Well, because that risk of a serious tear to the anus is such a big deal. The medial lateral, the angled cut, is now the most common and preferred type. The whole idea is to avoid those really severe long-term complications.
So what does the procedure actually look like? Well, it happens in a few key steps. First, and this is crucial, the doctor explains what's happening and gets consent. Then, they'll numb the whole area with a local anesthetic. The timing is really important. The cut is made with surgical scissors during a contraction, right as the baby's head is crowning. At that moment, the tissue is already stretched super thin. After the baby is born, the doctor carefully stitches the incision back up in layers, typically with sutures that just dissolve on their own. Okay, the baby is here, and now the focus shifts to recovery. Let's talk about what comes next, what you can expect while you're healing, and what some of the potential risks are.
Taking care of yourself afterward is all about being gentle and smart. The big things are keeping the area clean and dry. To help with the soreness and swelling, ice packs are your best friend, and so are sitz baths, which are just shallow, warm baths. You'll also want to eat a lot of fiber and drink plenty of water to, avoid straining. Pain relievers help a ton, of course, and down the road, doing Kegel exercises is really important for rebuilding that pelvic floor strength.
And a big question people have is, how long does healing take? Well, the standard recommendation is to wait about 6 weeks before resuming sexual intercourse. That's really the time frame needed to let those tissues heal up properly and to avoid any setbacks or complications.
And look, like any surgical procedure, an episiotomy isn't without its risks.
You've got the more immediate stuff like bleeding, swelling, or an infection, but there can also be longer-term issues like the scar being tender or intercourse being painful for a while. It's just really important to know that these things are possibilities. Okay, this brings us to our last section, and honestly, it might be the most important part of this whole conversation, because everything we've just talked about has been put under a microscope in recent years, and it's led to a huge shift in how doctors think about episiotomies. And here it is, straight from the World Health Organization, routine episiotomy is not recommended. I mean, that's pretty clear, right? We're talking about one of the biggest health authorities in the world. And routine use means doing it for pretty much everyone, which used to be the standard. This is a complete 180 from how things were done just a generation ago.
So what happened? Why the huge change in thinking? Well, the simple answer is science. Decades of research started piling up, and it pretty much blew up the old beliefs. Study after study showed that natural tears often heal better than a surgical cut. Patients reported less pain, and there were fewer long-term problems like incontinence. The evidence just became impossible to ignore. The old idea that an episiotomy was always better just didn't hold up.
So here's the bottom line, the big takeaway. The goal isn't to get rid of episiotomies completely. No way. They are still an incredibly important tool for doctors in very specific, high-stakes situations, like if the baby's in distress. The new standard isn't never, it's selective. The idea is to use it only when it's absolutely medically necessary, not just as a matter of routine.
And that really brings us all back to you. Knowing the history, the procedure, the risks, and especially the modern medical thinking, that's powerful stuff. It helps change the conversation from one that might be based on fear to one based on being informed and making choices. So we want to leave you with this question. Armed with this knowledge, how does this change the conversation you can have about your birth plan?